Good morning, ladies and gentlemen. Hello, dear friends. My name is Vasily Rahovi. I am the hand transplant patient from Innsbruck, Austria, and the founder of the Voice of VCA Patients. Welcome to the interview. Today, our guest is Professor Simon Talbot, an associate professor of surgery at Harvard Medical School, director of the upper extremity vascular transplantation program at Brigham and Women's Hospital in Boston. Professor Simon Talbot is an outstanding surgeon with a unique experience in performing both hands and face transplants. Good morning, Professor Talbot. Nice to see you. Thank you for joining me today.
Thank you very much for having me. It's a pleasure to be here, Vasily.
Thank you very much for your time, Professor Talbot. I know you are a very busy person. Thanks a lot. Professor Talbot, you have a very interesting professional background. You are originally from Auckland, New Zealand. First of all, I would like to ask you to tell us about your medical career in transplantology. How has it developed and what brought you to VCA in Boston? Is there any VCA programs in your home country?
So I've been incredibly fortunate in a lot of ways as far as my career has gone because, a lot of people plan their career out since they were a kid. I didn't. I was very lucky that things came my way and I was able to take opportunities as they arose. And yet at the same time, I will say that when I was a kid, there was a lot of excitement about medical advances and the opportunities for bionics and things like that. So I kind of sort of thought about these things as a kid, but the ability to get into the career of VCA and hand surgery and plastic surgery did not happen in a structured way. I finished my medical school in New Zealand in around 2000. Then I was offered a job in research in New York, and so I spent 2 years in New York, and then came to Boston to do my plastic surgery training under Julian Prebaz and Elof Eriksson, and then was very, very interested in hand during that time and did my fellowship with Joe Upton at Beth Israel Deaconess Medical Center in Boston. And it was exactly that time, around 2009, 10, and 11, that transplant was taking off around the world. And so my first job at the Brigham, I was sort of hired in to direct upper extremity transplantation. Just the timing was perfect, and involved in cases right from the very beginning of hand transplantation in the US. So good luck rather than good planning, but at the same time, sort of opportunities arose that were exciting and kind of in my career pathway. And then your second question was what is available in New Zealand?
Are there any VCA programs in your home country? Maybe
Yeah.
that was so to say a push for you.
New Zealand's very small, both
Mhm.
numbers of people and in terms of a medical healthcare system, and the resources that are required for a VCA program are really extraordinary. And so, although there are a handful of patients who would be appropriate, and the doctors there would be completely capable of running a hand transplantation program and doing the surgery, I think for a really small country, it's a big hurdle to get through the resources. So I don't know if that will happen in New Zealand or if it would be more sensible for New Zealand and Australia to team up. I'm not sure, but right now they're not running a VCA program in New Zealand.
Thank you. Harvard Medical School is one of the best in the world, maybe the best. Could you tell us, please, what types of external organ transplantation have you and your colleagues already performed at your hospital, and what VCA programs are you currently working on? Is the VCA program hand transplant or face transplant still active today or not? How does it look like?
Yes. So we have an active hand and upper extremity transplant program. That's where my primary responsibilities lie. And we continue to follow several of our own patients, and we have several patients from outside of the area who have moved here and get their care locally. We have a protocol for lower extremity and uterus transplants, although to date those haven't been done at our hospital, but there are people interested in doing them, and so they're open and an option. We had done quite a number of face transplants
Mhm.
under Dr. Pomahak. He moved to Yale, and so he has taken that part of the program with him. So we're not actively doing face transplants here. The other part, of course, is any big VCA program like ours has a strong research component. So as well as clinical care for these patients and clinical protocols for extending into, things like uterus and lower extremity, we have a fairly strong research program on rejection and immunosuppression in collaboration with our colleagues in solid organ transplantation. We have a program looking at nerve regeneration. And my personal interest is really looking at psychosocial outcomes in patients and the psychosocial impacts of these kind of operations on people and how we can integrate an operation into somebody's life. Because as you know, and as other VCA
Yeah.
candidates know, it's not just about doing an operation and saying goodbye. That works when you have your gallbladder out or when you have your a tooth extraction or something. But for
Yeah.
VCA, this is a lifelong commitment to
Yeah.
medication and research and rehabilitation and things like that. And so we have to make sure that we're doing the best for patients psychosocially as well as just physically. So that's sort of where my research lies as well.
Mhm. Professor Talbot, what are your key duties during the VCA surgery? Do you take part in the surgery or just supervise it? Could you tell us please about that?
That's a really, really good question, and it gets into the nitty-gritty of what actually happens when you do an
Yeah,
operation, and it has
yeah.
evolved over time. So the very first VCA case, I flew out of state to help procure the limbs on a patient, and actually it wasn't out of state; it was in state. But anyway, I helped with the procurement of limbs, and I realized that I was out of the my own institution, and I was trying to help coordinate things at my home institution while I was somewhere else completely.
Mhm.
Then the next couple of times I stayed locally to try and take care of the patient that was receiving the limbs and had my
Mhm.
colleagues travel out of state to procure limbs. And as I got deeper into it, I realized that the most important role is probably actually coordinating and being the coordinator of everything that's going on. So I do take part in the surgery, and I usually start the surgery
Mhm.
with the team. As a lot of us working together, start the surgery with the team locally. But as things progress, what I try and do is help coordinate swapping in different surgeons into different roles that they might be really good at. For example, if somebody's really good under the microscope when we're starting to put nerves together, I'll ask that person to come and take over. Or if someone's been up a really long time and they're struggling, we'll switch someone else out. And then we also coordinate things like how long things are taking so that our length of surgery isn't so long that there's a problem with poor tissue perfusion or ischemia of the tissues. And so there is a large coordinating role. What I will say is that the other thing that I've learned as we've done this multiple times and also practiced this many times is that a huge part of this can actually be coordination that you do ahead of time. So we have specific checklists for each surgeon at each site and specific roles for everybody. And we try and coordinate those roles, and everybody should know what they're doing well ahead of time. Now things change and problems arise that you have to pinch hit at the time. But a
Mhm.
huge amount of this stuff is actually coordinating ahead of time. So yes, I'm fortunate that I can be part of the case, but also oversee it. And I think I've matured in my thinking that this isn't about doing as much as you can yourself, but rather recognizing who's the best to do different parts of these cases and working together. I will also say, and I sort of alluded to this before, that um, the actual surgery happening itself is often a smaller part of the bigger whole. The preparing the patient over the year ahead, getting EMGs and CT scans and MRIs and functional MRIs and good exams of the patient, and then the post-op care, critically important. Hand therapy, management of their immunosuppression, biopsies, following along with all of those other aspects that you know of is a huge part of it as well. And I
Yes.
do think that we tend to focus on the operation and then everybody disappears. I always think it's a little bit like when people have a baby. Everybody's there the day the baby's born, and then everybody disappears. And so actually that is the other big part for me is being the parent, still being there
Yeah.
and taking care of everything the whole time. And I'm really lucky. I mean, I have a fabulous team. I have doctors where if I was unable to do something, there's tons of people that can join in. And so, it's one of the reasons why in a big institution like this is more doable than if I was by myself somewhere where I couldn't provide the type of care that I think we need to do for patients.
Mhm. Very interesting. Thank you. So to say you take part not only in the surgery but also in follow-up. Can
Oh,
we?
100%. I mean,
Yeah.
I have been following some patients now for, I'm trying to calculate it out, but 15 years, and seeing these patients regularly. I mean, realistically, that is one of the really fun parts of this, which is
Mhm.
seeing patients sort of mature and use their hands and as much as possible get back to the kind of lives that they want to live. I mean,
Yeah.
I think that uh, there are certainly surgeons who just like surgery. Um, I don't think I'm unique in this, but I think, unlike some surgeons, I really like to actually take care of patients, and I
Yeah.
enjoy being around patients and seeing what they're doing. And I think that actually helps us get better as a field. If we don't know how patients are using their hands, and we don't know the challenges they have on a daily basis, or we don't know the negative impact that can happen from a severe rejection, or we don't know the subtle complications that come from the medications they're on, like, well, like poor kidney function, like ultimately maybe needing a kidney transplant, like neuropathy where they lose sensation, or chronic rejection. If we don't know palpably what those things entail, it's very hard for me to educate a patient coming in as to what the risks, benefits, and alternatives are for them. And it's very hard for me to focus on the things that matter in terms of research. When I know what you're going through and what your frustrations are and what you'd like to have improved, it's much easier for me to then go back to the funding sources or look at those doing research and say, this is the research that needs to happen, not that
Mhm.
research, or this is
Mhm.
the area that people are struggling that we need to be thinking about, not something else. So, I do think that's an important part of it. Following patients'
Mhm.
outcomes is the only way that we can actually make this a better procedure and focus on what's important.
Mhm. Prof. Talbot, we have started talking about patients and follow-up. Therefore, I would like to ask you about one of your interviews. You said that feeling of frustration have not only patients if something goes wrong, but also their doctors. I
Yes.
think it very important, not especially for VCA patients. Yes, to understand that we and our doctors have the same goals, the same hopes, and so on. Prof. Talbot, maybe this concept should be a part of preparation for the surgery. So to say, to give the patient's feeling of being part of the team. How do you see this?
Yeah, I'm really pleased you bring this point up because this is a really important concept that I feel transcends VCA. This is medicine in general, and it's misunderstood by a lot of people, which is when you take your car to the mechanic and they fix your brakes and you leave and the brakes are squeaking, you can be frustrated and annoyed. But if you take your car back to the mechanic, my suspicion is that that mechanic doesn't say, "Oh, just so frustrated. This is such a problem with these brake pads." But I would tell you it's different when you're dealing with a person. And this is not just VCA, this is everything we do. We take so much pride in what we do, but
Mhm.
it's not just the pride we take in the work we do, it's the fact that what we do impacts someone viscerally. And that's a terrible metaphor, but it impacts people in a way that is so core to being a human, right? One of the
Mhm.
things that we do in medicine is we try and make people better. It might be that we make them function better or their health better or their lives live longer, but it's we try and fix people, we try and make things better for others. And so if that doesn't happen, if someone has a terrible rejection episode, if someone's
Mhm.
life is shortened, if someone's quality of life is decreased, that's incredibly frustrating. Is really maybe I used that word previously. It's not really the right word. It's more it's incredibly impactful on both the patient and the doctor. So I
Mm-hmm.
think I hope it's helpful for patients to hear that I really struggle when things don't go well, and I'm doing everything I can to fix that. I think it's also helpful for doctors to hear that when we don't get the outcomes we wanted, how important that is for patients and how impactful that is for patients. It's why I work in this area of psychosocial well-being, because I
Mm-hmm.
think it's really important. I will also say that the struggles that patients and doctors have allow them to be a team, and I think that's a little bit of often it's sort of a throwaway comment that people use in medicine. You know, you're doing a big operation, you say, "Oh, we're a team on this one." I think people often overuse that, but in VCA, it's absolutely true
Mm-hmm.
because you need somebody who is your eyes and ears for rejection, and that's my patient, right? They're the ones
Yeah.
seeing their hands every day. I need families that are the cheerleaders for when you get depressed after surgery and you're struggling to get through all these exercises and take the medications. And even when things aren't always going well, you need that cheerleader who are the family. And so we originally, 15 years ago, wrote a protocol for rehabilitation for hand therapy after hand transplant, where we said, here are the exercises you do, and here are the mirror exercises you do. So you integrate the hands into your own brain, and here are the stretching exercises you do in the splints. And one of the things we said originally was like, you need to come into the hospital 5 days a week to get your occupational therapy. And
Mm-hmm.
as we've got more experience with this, we said we don't need to do that. What we do need to do is educate you and your family about what you're doing at home every day. And not only that, we actually have a prehabilitation where it's not just knowing how to get you better after the surgery, but it's before surgery as well, and having your family learn all of those things and you learn all of those things ahead of time, so that when surgery happens, it's just following the game, right? It's a game
Yeah.
plan already put out. And so again, that's this concept of the team that you've got working together to achieve that goal. So the patient is an absolutely critical part of that team, and it sounds sort of cheesy, but it's not. It's really true.
Yeah. Yeah. Thank you, Prof. Talbot. Prof. Talbot, may I ask you a beginner question? I think it would be interesting for our viewers to know. There is a big difference between facial surgery and hand surgery. Yeah,
Yes.
and at your hospital, there have been also done not only hand transplantation but also face transplants and other surgeries. Does your team consist of several uh, surgical groups or teams specializing in different areas of surgery, or how does it work? So to say, you can be specialists in all areas, or it is possible. Could you explain it out to us, please?
Uh, it's a great question. Great question. So, in hand transplantation, we generally have plastic surgeons who specialize in hand surgery,
Mm-hmm.
and orthopedic surgeons who specialize in hand surgery. We work together on a lot of non-hand transplant patients, but we, of course, come together for hand transplant as well. That said, there are a lot of plastic surgeons who are very well trained in microsurgery. So while they may not be experts at hand surgery, they're really, really good at putting little tiny structures together. And
Mm-hmm.
so oftentimes our team consists of about half hand surgeons who are
Uh-huh.
very comfortable with tendons and nerves, and small blood vessels, but we'll also get help from our colleagues in microsurgery who will come in and similarly also do some of that work. And then we'll have our orthopedic surgeons do the bony work. So there are definitely specialized parts, but there are very common skills between those different groups. For face transplantation, which Dr. Pomahag leads down at Yale
Mm-hmm.
now, we have a handful of maxillofacial and craniofacial trained surgeons who will do a lot of that work. But then someone like me will come in and help put the nerves together because that's what I do all the time in the hands.
Mm-hmm.
So it is Yes, there are specialty aspects to it, but at the same time, there are a lot of skills that are very translatable and skills that are very sort of universal across plastic
Mm-hmm.
surgery, orthopedic surgery, craniofacial surgery,
Mm-hmm.
hand surgery. Um, it's one of the things that makes this really fun, if I can use that word, which is that you are sort of using all of the talents in your
Mm-hmm.
team, but also you are using the sort of extremes of what we're all good at, which I think is one of the really beautiful parts of these operations.
Yes. Yeah. Prof. Talbot, you are one of the key expert in VCA field. Yeah, nowadays, could you tell me, please, how much has VCA surgeries changed since performing of VCA surgeries changed since 1998 till 2026? I mean, how much have modern technologies such as 3D printing, artificial intelligence, transforming the way of planning and conducting VCS surgeries?
Yeah. Um, well, I'm going to give you a little bit of a disappointing answer,
Mm-hmm.
which is that my own hope was that we would have seen bigger changes over
Mm-hmm.
30 years than, well, almost 30 years, 27
Yeah.
years than we have. Um, when I first started doing this, I said to patients who wanted, for example, one non-dominant hand transplantation, I said, the risk is pretty high to you and the benefit is marginal. So come back and see me in 10 years' time. I hope that there'll be better immunosuppression and
Mm-hmm.
less complications and things. Then let's talk about it in 10 years' time. And the truth is that when patients have reached out to me again, that there's a few things that are better. We
Mm-hmm.
are better with how we run our immunosuppression, and there's a few new immunosuppression drugs.
Mm-hmm.
I think we know what to look for, and we have better expectations. I think we have a better understanding of the psychosocial impacts, and what psychosocial readiness for surgery looks like.
Mm-hmm.
And I think there's lots of sort of incremental things that we've got better at. Our team has got better at coordinating surgery. We've got better at figuring out what the key parts are and what the not so key parts are. We've
Mm-hmm.
got people who work together in a team well. Um, and we've got our sort of protocols of how much follow-up do we need? How often do we need to see you? How much
Mm-hmm.
occupational therapy is enough without torturing somebody by making them turn up every day, which I always feel a little guilty about. So I think we've made incremental improvements. I don't think we've had the game-changing improvement of what do we give someone that prevents them needing immunosuppression, or how do we do surgery such that this arm feels immediately like a part of their body and is working. We haven't figured out how to get nerves to work faster than a millimeter a day of regrowth. So there's a handful of areas, particularly immunosuppression and nerve regeneration, that are still the Achilles heel of hand transplantation.
Mm-hmm.
I liken it to, for example, gallbladder surgery, where for decades and decades we made a big long incision underneath someone's rib to take out their gallbladder, and we thought that was the best way to do it. And then in the 1980s and 1990s, we developed how to put in little tiny fiber optic cameras through 1 centimeter incisions and take the gallbladder out through the belly button and then close that up, and the patient goes home now the same day.
Mm-hmm.
Now, they got better and better and better at doing open gallbladder surgery with a big incision. But when someone made that leap to doing it with a tiny little camera through long keyhole instruments, that completely changed everything about it. And I think the same will be true for hand transplantation, which is we keep making small incremental improvements. But the day that someone comes down and says, I figured out how to create a chimeric immune system where rejection is an infrequent occurrence, or the day we figured out how to have rejection drugs that target the transplanted limb but don't
Mm-hmm.
affect the native body, like the kidneys of somebody. Um, the day we do that, it will be the dramatic change, and we always have to keep working at the incremental things so that one day we make that huge leap in another way. So yes, the changes we've made in the last 3 decades have been incremental, but they're the building blocks for us to make a huge leap forward and no one ever knows when that spark of idea or magic drug or whatever will be found that will make nerves regenerate immediately or trigger the immune system to recognize a foreign part as self. So that's what I'm excited about, is those giant leaps forward. You just don't know when they'll happen. So every time I go to a conference, I'm like, is this the giant leap? Is this the giant leap? Or what's the new idea that we should be thinking about?
Yeah. Prof. Talbot, you have mentioned unilateral hand transplantation. And as you know, there is an ongoing discussion with the community whether is it ethically justified or not to perform the unilateral hand transplant. And I would like, you have partially answered that questions, but
Yeah.
do you think the personal motivation can influence the ethical concerns and the concern of the doctors that it would be the patient would benefit from this surgery? Uh, Maybe every case should be considered separately. Could you answer this question, please, too?
Yeah, no, it's another very, very good question. Um, there's a number of different ways of looking at it. There is the perspective of ethics, right?
Mm-hmm.
Autonomy, beneficence, non-maleficence. Like, how do we um, uh, how do we balance the risks and the benefits for any one individual while still maintaining the idea that they have autonomy to make these decisions? And so, in that way, an individual patient making that decision with their doctor is a critically important decision. And so I think you can justify it ethically when somebody is well educated about what's going on. They've spoken to another VCA recipient. They understand their limitations and they understand the upsides of a unilateral hand transplant, and they understand the downsides. So I think you can ethically justify it in that way.
Mm-hmm.
If it were me as a patient, and I tend to come back to that quite a bit, would I do it given that I feel I'm probably about as educated as anybody in the world about what the upsides and the downsides are? And I've seen patients go through the really good things, and I've seen patients go through the really bad things.
Mm-hmm.
So I think I can probably say for me
Mm-hmm.
that a unilateral hand transplant is not something I personally would feel I wanted, because I've got lots of patients who have one hand or one arm. I've got lots of young people who are born with one hand or
Yeah.
one
Mm-hmm.
arm and are highly functional and have very, very fulfilled, effective lives. Um, and so for me, the need to be on anti-rejection drugs and to have to be near a hospital if a problem happens, and these things to me are challenges that I would not want to go through. However, there are certainly patients that I've spoken to who would do that in a heartbeat because of all sorts of personal things. They need this feeling of wholeness. They have a
Mm-hmm.
particular activity that needs both arms, and that's a really important activity for them. For example, we all know somebody who rides a motorcycle, and that's really important.
Mm-hmm.
And so if there are so I think it's justifiable ethically, but I think it's a much harder sell to me as a human being and as a doctor who knows about this than a
Mm-hmm.
bilateral. When I have someone who comes in, well, I'll give you another example, and it's a little bit of a long-winded story, but I think it's an important one that I tell other doctors all the time. I get patients who come in missing their left non-dominant hand at the wrist. And their function, let's give it a number, might be 95% of my function. They're missing their hand, but they're very functional. They can do just about everything that I can do, almost.
Mm-hmm.
And if I put a hand on there, I can probably get them from 95% function to 97% function. I can give them a 2% increase in their function because now they have a hand which will be a little numb and won't have totally normal motion, but
Mm-hmm.
allows them to use it as a helper hand. So
Mm-hmm.
I can get them a little bit better.
Mm-hmm.
I tend to think that the risk for that patient to get 2% increased function is very, very high.
Mm-hmm.
However, I see a patient who comes in with through the humerus amputations. Their function is profoundly impaired, and even their psychosocial well-being is profoundly impaired. They can't brush their teeth independently. They can't undertake hygiene independently. They can't feed themselves independently. And they may have workarounds that allow these things, but their day-to-day function is profoundly impaired. And if I put limbs on that patient, those limbs will never function as well as the one that gets transplanted at the wrist level. So let's say they started out with 25% of normal function. And again, that's a charged term, but you get the point. I might get them from 25% of normal function to 45% normal function. I give them a 20% increase, but now they can toilet, they can feed, they can get out of the house if there's a fire. Their function may not be perfect by any of our standards, by any of the measures, but it's profoundly better than what they were before. And that person probably would trade a few years of life expectancy for that better function. Whereas I think it would be a hard sell for the person who's got the wrist level amputation to trade a few life years for that incrementally better function. So there are some interesting challenges we have in hand transplantation, which is when we started out doing this, we didn't do above elbow transplantations because we said the function will be poor. But the difference between where you started and where you finish is so great that I think poor function is a relative thing. It's not an objective, your function's not perfect. It's your function's way better than where you were. I had one patient who said to me, for the first time in over a decade, I can now be home by myself because if there's a fire, I can get out of the house. I can dial my phone. I have safety. And it never occurred to me that before that, this patient couldn't be left at home by themselves for safety reasons. So there are this is where being part of the team is really important because we hear these things that you otherwise don't even think about.
Yeah, you're right.
Does that answer the question? I hope
Yeah.
it does.
Yeah, it is. Yeah, absolutely. Prof. Talbot, we have also started talking about nerve regeneration. Could you explain to our viewers, please, why nerve regeneration is so crucial after a hand and face transplantation? And is there any difference in nerve growth rate between hands and between transplanted hands and transplanted face?
Yeah, great question. And um,
But you
I'm
understand
mindful.
why is it important, but yeah,
Yes, yeah,
majority of our viewers don't anything about that.
yeah. No, it's a favorite question because it's an area I literally flew down to Washington D.C. to Walter Reed to operate on pigs for years in a row before COVID to try and figure out how we could make nerves regenerate better in
Mhm.
animals and mammals and of course people for this reason.
Yeah.
Um, Nerves, well, there's two types of nerves. There's peripheral nerves, like in your hands and face,
Mm-hmm.
which grow at a millimeter a day. They regenerate from the point that you cut them distally by a millimeter a day. There are
Mm-hmm.
central nerves like your spinal column, like your optic nerve, and like your brain that
Mm-hmm.
don't seem to regenerate. I think it's important to say that because that the optic nerve and the spinal cord and the brain are the Achilles heel behind some types of
Yeah.
repair. That's why people who are paraplegic we don't recover after a spinal cord injury typically.
Yeah.
It's why eye transplantation has this challenge, which if the optic nerve won't regenerate,
Yeah. Yeah.
then we're not going to be able to get vision back.
Yeah.
So we're really talking about peripheral nerves. That's the nerves that run to the fingertips and the nerves that run into the face to give you smiling and motion of the face and
Mhm.
also sensation.
Yeah.
Those nerves regenerate about a millimeter a day, or about an inch a month. And it's a slow process and is important to get both sensation and motor function. So motor function is
Mhm.
moving the muscles, sensation is what you feel on the hands and in the face. Um, the differences are not the speed at which those nerves grow, but the distances which they have to grow. So if I transplant an arm up here, I might have 60 centimeters before that nerve will reach my fingertips and give me sensation. Or I might have 30 centimeters before it will get to the muscle that allows me to grip with my hand. So
Mhm.
you can imagine that those are a year or more of regeneration that's required. In the face, the distances are very short. It might
Mhm.
be 6 centimeters or it might be 3 centimeters. So we're talking much shorter periods of time for them to regenerate. So that's one difference is the distance those nerves grow.
Mhm.
The second
Mhm.
big difference is um, is what they're doing. The most important part of our hand are at the very end of it. It's sensation and motion of the
Yeah. Yeah.
fingertips.
Yeah.
In the face, you know, the oftentimes we're transplanting the skin of the face, but the muscles are intact. So the person has muscle function right away. And if you don't have normal sensation in your face, it's not really a disaster. If you don't have normal sensation in your fingertips, you burn them, you damage them, they get hurt. So there's a difference in the level of importance of motor function and sensation. I'm a hand surgeon, I'm biased, but I would say motor and sensation in the fingertips is more important than motor and sensation in the face. So those are the big differences when it comes to nerve regeneration and what's going on in faces and hands.
Mhm. Sensation of the lips also belongs to the nerve regeneration.
Yes, sensation of the lips does belong to it and is an important part of it. The nerves that do that are traveling from lower lip down here. They've only got a couple of centimeters to go. Um,
Hmm.
I do think that the facial nerves, there's so many of them that there's so much redundancy between them. There's a lot of overlap between those nerves because we have so many in our face. You know, there's 5 branches to our facial nerve. Whereas in the hand, they're sort of like a freeway. There's 3 big nerves that come down and then branch out. And so you're relying on these bigger nerves in the hand versus smaller nerves in the face that are far more redundant and cross cover one another. So
Hmm.
there's that issue as well. It is an area that we're all there's certain strategies that we're working on. For example, putting in nerve grafts, like putting in an artificial nerve ahead of time so that that nerve has time to grow before you attach a hand is
Hmm.
one strategy we've talked about it and used in some situations. I will add one other complexity to the whole thing, which is that a nerve has to reach its muscle target within about 12 to 18 months of
Hmm.
it being disconnected, or that muscle will sort of fade away. That's not true for sensation. You can always have a nerve regenerate sensation, even if
Hmm.
it's years afterwards. But
Hmm.
within about 18 months, if that nerve hasn't reached its target, it probably won't ever have much function. So when you add a limb on, like if I do a transplant at, say, the elbow, I have about a year for that nerve to reach these muscles here. And if it doesn't reach those targets, then those muscles will fade away and not be very functional. So that's why when we do a transplant, we see improvements that continue down for a period of time. But that first year is a really critical time to see how much better someone's muscles will get.
So to say, there are a few techniques to enhance some nerve growth, but they need improvement, so to say.
That's exactly right. Well, there's a number of things that different groups have worked on. We've worked on hydrogel impregnated or growth factor impregnated hydrogels to try and sort of shower these nerves with growth factors like you would fertilize a garden.
Mhm.
There are also different techniques people have done by grafting nerves early to give them time to grow before you do a transplant.
Mhm.
There are some drugs that we think, although have not been convinced, speed up nerve growth. And there is one particular product that we are working on to try and fuse nerves together where you get immediate function of that nerve right away, as opposed to the nerve having to grow. It just fuses together the same way as you might fuse together a fiber optic cable or something like that.
Mhm.
Again, still very much in its infancy, but those are the things that will really be a game changer as far as upper limb function goes. I think um, the nerve regeneration space is also particularly interesting because it transcends VCA. We see so many nerve injuries that are in people who are not VCA candidates or are not VCA patients,
Mhm.
where fixing nerve injuries or speeding up nerve recovery is really important. And so this is a sort of an exciting area because it affects just so many people as well.
Mhm. First about, is there any connection between the size of the transplanted issue? I mean, the hands from shoulder, yeah, and or face, and the level of immunosuppression that patient can must take after the surgery. Is there such connection between these two things?
No, we tend to think of the immune system as a little bit sort of on um, you're either going to reject foreign tissue or you're not.
Uh-huh.
Um, and so we don't give more immunosuppression for larger limbs. But what does happen is one of the big triggers to rejection is tissue injury, whether that's a sunburn or the cold with dry skin and cracking skin, or an infection, or in your mouth biting your mucosa or injuring the mucosa. I even had a patient who got poison ivy, and that triggered it. So any injury seems to be enough to trigger our immune system to say, I'm going to stir inflammation. And when you cause inflammation, you can trigger the immune system to start rejecting a limb or a body part. And so the bigger your limb is, I suppose, the more likely you are to have a burn or have an injury or have a skin issue. And so there's that part of it, but that's a little bit of a stretch. Most importantly, I would say that injuries to the body are really what we worry about. It's one of the reasons why in Boston, and you would know this from Austria, when it gets cold in the winter and it gets dry outside, you get these little cracks in the skin around the nails and on the hands. And so in the winter, we will put our transplant patients on a little extra dose of prednisone to try and tamp down the inflammation, which can then so that we don't trigger an immune episode. We did find that in the winter we were getting more rejection episodes, and we think that was the reason. So really interesting. There's so many little insights that you develop over time about this.
Professor Talbot, is there any difference in immunosuppression therapy after the hand and face transplants? Do patients take the same immunosuppressions after those surgeries or not?
So I can really speak to the hand transplants, where our traditional has been starting off with triple immunotherapy. Tacrolimus, mycophenolate, and prednisone. And sometimes we've been able to taper off the prednisone. We've had a few patients where we've felt, for example, one developed a particular type of cancer, and we changed him from tacrolimus to sirolimus. And actually tapered off his immunosuppression dramatically during that period of time to treat the cancer. We've had another patient who didn't do very well on tacrolimus. We just couldn't get the levels correct. And so we eventually changed him over to a very long-acting tacrolimus, and then added in belatacept, which is another type of immunosuppression, which is particularly good for the kidneys. So we generally start the same way, and then we adjust as we see some people do better with one thing and some people do better with another. And it's really something that, I'm not an expert at that. This is why I have my transplant colleagues who do kidney transplant and liver transplant, who are always thinking about this and always adjusting things. They're really fantastic at knowing what the next big thing is. And so, yes, we start with a standard regimen, and then we adapt it to the individual when we see how they do with it.
Yeah, understand. Yeah, Professor Talbot, you are not only an outstanding surgeon, but also a very intelligent person. And
Thank
therefore, I
you.
would like to ask you, where are the boundaries of the VCA? We have started with the hands, after that was face transplant, but what would be the next step? The brain?
Yeah.
How do you see the future, so to say, of
Yeah.
VCA in this?
I love this question because it lets me sort of dream about where we're headed.
Yeah.
So I was asked about brain transplantation in an interview back, I think it was in like 2012 or something. And my wife always teases me because it was a television interview, and I had this look on my face like, what are you asking me this for? But I think it's a really good question because, like, science fiction comes up with stuff
Yeah.
that's sometimes crazy, but sometimes practical. So I don't think we're about to do any brain transplants in the near future, even though that's actually been in the media a little bit, mainly because of what I mentioned before, which was regeneration of the central nervous system. Even if we could transfer the brain with its blood supply, which seems incredibly unlikely because the brain is so sensitive to poor blood flow, as we know from people who get strokes from the world's smallest little blood clot. But even if we could do that, I think that if you can't regenerate the central nervous system, why transplant a brain? Because then you've basically created a quadriplegic, which I'm not sure should be our goal. I also think if we do figure out how to regenerate the central nervous system, probably we should start by fixing the spinal cords of as many paraplegics and quadriplegics as are out there. That would be the most benefit we could give to the most people. So that's sort of my goal with brain transplant. And then my other thought on brain transplant is, where are the limits of transferring someone's soul? We all say our soul lives in our heart, but in my opinion, our soul lives in our brain in some way. And I'm not sure that transferring a soul from another person is a goal that I feel particularly comfortable with. But to broaden the question and say, where are we headed with this? I think there's two big areas that I'm excited about. I'm excited about the point in time when we get our immunosuppression better enough that we're comfortable transplanting small parts of the body. Right now, for example, we say, let's transplant a hand, but let's not transplant a finger or a thumb. Instead, we regenerate that from other parts of the body. We take a toe, we put it where the finger was, or whatever. But I would be excited if we had good enough immunosuppression management or targeted immunosuppression so that we could transplant a thumb and not have to worry about reducing life expectancy, damaging kidneys, damaging livers, all those kind of things. That's the first thing. The other thing is, I think it's the interplay between biotechnology and bionics and transplant, because I can imagine a time when we can take a donor limb and decellularize it and repopulate it with your own cells so that you don't see it as foreign. Or where we can take a transplanted limb that's not working perfectly and add in an electrical system to give you back sensation or motor function, or where we can take a biomechanical device like a prosthesis and seed it with your own skin and cells, so it might be mechanical on the inside but looks like your hand on the outside. These are things that are very science fiction, and there's nobody who's sort of close that I know of right now. But I think that if you look at where we were 100 years ago, maybe 110 years ago, where we were just starting anesthesia and we were just starting to be able to do internal surgeries safely, and we hadn't even figured out antibiotics yet. I think 100 years from now, it's very conceivable that we will have figured out some of these sort of biorobotic devices and things like that. So I'm not going to say anything political here, but there are opportunities for us to use the incredible resources we have in some areas of the world to do things like that, as well as all of the other, making electric cars and going to space. To me, these are things that kind of go together, and I really hope that we can use the technology and intellect and expertise that allow us to be a destructive human race to also be a constructive human race and do things that benefit the most people as well.
Yeah. Thank you very much, Professor Talbot. I'm very grateful to you for this very interesting and educational talk and supporting our patient initiative, raise awareness about VCA. I wish you success in your difficult work and strong health for your patients. Have a nice day.
Thank you. I wish you the best too, Vasily, and thanks for inviting me, and thanks for being part of my team as well. I appreciate it.
Thank you very much. Thank you very much.
All right.
Yeah.
Here.
Goodbye. Take care.
Bye-bye.